It does bring up the whole issue of the complexity of these kids. Some of these conditions are so rare that you've never heard of them before they front up, and the parents are the experts.
Part of this challenge to me is linked to that in this brave new world of both technology and social media and also, genomics, is recalibrating our expectation of what does a good health system look like.
Hi, this is Connect, Pause and Reflect, CPR for clinicians. In this series, we hear from paediatric clinicians from across Australia who joined us as part of a 4-year research project to share their reflections on the experience of delivering care for complex patients. Our hope is that their shared reflections may help others to feel empowered, more connected, and able to appreciate how they make a difference to patients and families and what sustains them in the many challenges they face. The focus of today's episode is the complexity of modern medicine. In the first half of today's episode, clinicians reflect on some of the complexities around rare conditions, the development of new treatments, advances in technology and genomics, and the pressures of social media. In the second half, clinicians working in remote Central Australia reflect on the unique layers of complexity they navigate when delivering care in their local context. Up first, the complexities of supporting the families of children with complex conditions.
It does bring up the whole issue of the complexity of these kids, the reality of the time that you can devote to these kids, which without support just means that you're not going to succeed. So the whole recognition that you can't do it by yourself, that you have to have relationship building between you and the family, between you and the other teams. Some of these conditions are so rare that you've never heard of them before they front up, and the parents are the experts.
As a clinician, one realizes that there isn't one size fits all in dealing with families with grief and loss. There are those families who are accepting of what you're telling them because through working with them, they believe that no stone has been unturned. But that's changed as well as new treatments have become available, so that one used to be in a position where one could say everything has been tried, whereas today, with all the new treatments available, there are an increasing number of families who are saying, but isn't there something elsewhere? And to an ever-increasing extent in oncology, certainly, and in many other specialties, there are things that we would never have dreamed of trying, but that adds to the challenge and how one has to learn and support the families that you're dealing with.
There was a time where we would delineate palliation and therapies would stop. But much more really, it's most common that a patient would die on experimental treatment, not without good reason, but because of the number of options. Very often that has continued on a lot longer than perhaps in the past. I'm not saying that's wrong at all, but the complexity of in the family's mind of what is hope, what do we hope for, realistic cure, is it helping quality of life, are we addressing the life-ending issues, it makes it a harder thing to navigate.
In the next section, clinicians reflect on the emerging complexities around advances in treatments, technology, genomics, and the modern pressures of social media.
So I think around the trials and the precision medicine stuff, we have so many common threads and problems, and yet we don't have common mechanisms and frameworks to discuss these things and workshop solutions together. We all feel like we're carrying the world on our shoulders for each individual case. There must be better ways of navigating these things collectively, where we're learning from each other. But we're also busy, and we're also catching up with a paradigm that wasn't in existence 10, 20 years ago. So I would like to think in my professional role that I can proactively try and bring some of those things, work with other people, I do it all myself, but to bring some of those things into action.
We've talked about it, genomics, clinical trials, technology, and with that has come, I think, a great complexity about decision-making in this kind of context with these families, trying to keep the child in the centre. The idea of course I can, should I? The absolute responsibility of consent and how it's done. Should a phase 1 trial be offered to a child who has an incurable illness? How do you weigh advance against what is the need and fairness of a child?
Part of this challenge to me is linked to that in this brave new world of both technology and social media and also, genomics, is recalibrating our expectation of what does a good health system look like. So then in this world where we're doing very specialised things and there's this new level of medical technology and there's also expectations around social media and contactability, what does the health system look like then that works for these families, but that we can survive in as well?
In contrast to some of the complexities experienced when working in larger metropolitan or very specialised centres, clinicians working in remote locations face a range of different complexities. Up next, clinicians from Central Australia reflect on some of the issues they face around health literacy, lower socioeconomic status, and navigating conflicting priorities between clinicians and families, along with some of the ways they've reframed their approach to help make the ongoing challenges they face less distressing.
Health literacy in Central Australia on average is very low. So, we don't have parents coming in demanding cutting edge therapies very often. We do get a little bit of that, but for the majority of our patients, it's bringing them on a health journey with us rather than having demands placed upon us for those things.
There's this battling frustration between the modern advance in medicine and money going into these highly specialized areas where the actual problems are people don't have houses and jobs, which is very frustrating, I think, for us. It's like if you take away all of these orphan drugs that are out there, you could build a few houses and solve a lot more problems.
We just have so many families with conflicting priorities, but they might have really unwell children, but they can't afford to travel or they can't afford to contribute to their care. Someone else in the family caring for them, or they might not be able to feed themselves while they're here for appointments. So I think all that baseline stuff that we can take for granted in other places is fundamental to engaging with families here.
In the next section, clinicians reflect on the self-care strategies they've adopted and the ways they've reframed their approach to help make the ongoing challenges of delivering care in Central Australia less distressing.
We have kids who get poor diagnoses and you know that their prognoses are even worse because of the background in which they live and the other complexities to their life, and then have to process your own feelings to then be the doctor for a family that's going to actually be the ones to go through this. So managing yourself so that you can be a human doctor is important.
We really focus on the smaller things that probably in other jobs I wouldn't have celebrated so much. But like patients who have attended hospital or their clinic appointment that, they might not be strictly adhering to the medication or advice that you're given, but the fact that they've travelled from remote, or even if they've just made it from in town, with knowing their complicated and social histories and complex kind of impeding obligations they might be going through. I think things like that we really celebrate, and we try and talk about good news stories pretty regularly, because there are lots of good things. It's easy to get weighed down with all the negative things, all the things that are hard and challenging, but there's lots of great things about working here and working with the families we work with. So I think trying to remember that is important.
My priorities are not my patients' priorities, and to kind of recognize that a lot of families that I see come because they have been paternally told to come to appointments or to come in, but it's not actually at the forefront of their minds. They've got a lot of other family or cultural obligations or other pressing matters. And so what I see as important doesn't necessarily mean that they see it as important. And I think that helps with my levels of distress around those kind of things. And then in that same vein to, take those small wins, which might only be attendance or might only be engagement, giving them the opportunity to and the education to, and setting them up so they might at any point decide to engage. And I think it's, if you kind of reframe it like that, as opposed to looking directly at the patient and directly at their outcomes, it becomes less distressing.
Finally, in contrast to the many challenges, a clinician reflects on the enormous joys and privilege of working with remote Indigenous communities, the beauty of the land, and the rewards of working with incredible colleagues.
When people put Alice Springs into Google, unfortunately, there's just this media vendetta against this place, and all they see is negativity. So I always want to tell people that don't live here that that's not our experience of us that live here, and that it's a beautiful place to live. Like, it's physically beautiful, and there's so many, like, this really great community here. And from the work perspective, I think when registrars come here, they all have a great time. It's really medically challenging, so we manage really sick kids aside from all social complexities. So they get a lot of experience in all different areas. Also, I still feel like we're in a very privileged position to be able to work, particularly with our Aboriginal families, a lot who come from remote areas who have had limited interactions with big hospitals where most people looking after them are non-Indigenous. Hearing kids talk in a language that's thousands of years old is, I think, really special. Like, why wouldn't you want to come here? It's amazing. I think this is the hidden gem of Australia. I think it's just that this is a really special place.
That concludes today's episode on complexity. If you're interested in learning more about the research project behind these podcasts, or about hosting Connect, Pause and Reflect sessions in your workplace, further resources are available on the Sydney Children's Hospitals Network website. We would like to acknowledge the Cliniquip steering group led by Professor Annie Bai, including Fleur Leman, Professor Kenneth Nunn, Suzanne Nevin, Erin Beavis, Rachel McLaughlin, Rebecca McIntosh, Doctors Rani Sachdev and Elizabeth Palmer, and the Cliniquip Advisory Group who contributed to the co-design of these resources. We thank the Manildra Group for philanthropic funding. Thank you for listening.